So this is an incredibly timely topic, and we are putting pressure on the Department of Health and Human Services to find out where that information and when it will be available. And we'll make sure it is all part of our primary health centers and out in our portals and out to the community. So thank you for being here, and we'll kick it off.
Dr. Neal, do you want to talk a little bit about your experience with your patients and just a little bit of background, and then we'll go down and do the same for Dr. Dwight and Linda Crowell.
As Chrissy mentioned, I'm a family doctor and I work over at the community health center. I feel like doing training in Rhode Island, I saw a much different patient population than what I see up here. And so I think that I can safely say at least a quarter to half of my patients are women that are, either perimenopausal, or right in the throes of menopause, or they're postmenopausal. And so I have found that I have had to educate myself better to meet the needs of my patients. So I think that, it's very satisfying when I get to see women who start to talk about menopause and start to bring up the ways they're feeling. And, we have that conversation like this is normal. We just don't talk about it. And when they come back and they say, no, I feel better now because we've done some interventions, that is always great. I tell pretty much all of my perimenopausal women and menopausal women, these two books are amazing. Take pictures of them before you leave. They come as audiobook too, but they are really, really helpful as women transition through the stages of perimenopause and menopause. I think they can really just open up your eyes to like, oh, what I'm feeling is not strange. This is what my body is kind of meant to be doing. And it's a guide so that you can talk to your primary care about the different options that you want to explore.
I'm Kara Dwight. As you were told, I've been about 20 years. When I started out training, it was for menopausal symptoms, basically was Pro, and we tried to put patients on it, and we were all told that you were going to get cancer. And so everyone didn't want to take it. Thankfully, we're much more informed now with podcasts and books and women kind of taking their care back. Before, and ACOG, the American College of Obstetrics and Gynecology, just actually changed their criteria in the last year, where they said we can now prescribe hormones without doing blood tests, just based on symptoms, which is good because I've been doing it for a while. But it made sense. For a long time, we were treating a blood test instead of treating our patients. And it was highly frustrating, I think, for everybody. So I think we still have work to do, but it's definitely an improvement. I think women getting up and complaining, we're being heard about our needs. And it's not just, it was the change and we had to just go through it and it was natural. And, when people say that to me, I'm like, yeah, and 200 years ago, I would have been dead at 40. So I don't want to go through this naturally. So I'm assuming if patients want that option, you should know what options are.
Hi. I would say when I started working over at the Women's Health Center, an experience that sticks in my mind is a woman who was perimenopausal, which I never really thought about it, is when I first started over here. And she came in with a variety of complaints. Like she thought she was losing her mind. She was anxious. She was having palpitations, like all kinds of things. And I did this incredibly huge, probably very expensive workup, which like after a while, we kind of got to the point where she was like, and my periods are becoming farther and farther apart and I'm experiencing these things. And then it was like, oh, okay, well, it could be this problem, perimenopause. And we kind of addressed that. She did not enter menopause at that point. So we gave her some birth control and she just felt so much better. And I was like, wow, I have to look into this a little bit more. So it's a learning experience for me. And I do want to say that I think that with all the attention perimenopause and menopause is getting now, I feel people are looking at it as a disease, which it is not. It's a natural transition. But it is a transition that can be treated if a person is bothered by the symptoms they're experiencing. I just wanted to.
And Dr. Neal, could you repeat the titles of the books?
Yeah, absolutely. So the first one is The Menopause Brain. And that one's by Lisa Mosconi. She kind of, to Linda's point, she made me feel better about menopause because she kind of defines it as a evolutionary reason and she puts it in positive light. I think it's huge. And this one is The New Menopause. And this one's by Mary Claire Haber, and she has a lot of podcasts and other things available on different social media website as well.
Great, thank you. Okay, Dr. Dwight, did you want to start off and kind of give an outline and an overview to give kind of a common foundation to everyone? And then if anyone has questions, raise your hand.
As Linda said, perimenopause is when you still have a menstrual cycle. It could be normal or split out a little bit more. You're just not cycling through your normal hormonal ebbs and flows. Normally, your estrogen would go from 50 to 300, back down to 50, and then to 300, and your progesterone would be around 15. Perimenopause, you're going to hang out more at 50, and your progesterone would be 1. So you still can have a cycle. I tell people you're still hitting the ball, but they're all foul balls. They're not going where they're supposed to go. Some people don't have many symptoms. Some people have quite a bit. And that's where I do think we're getting better, and you can treat that with birth control pills or really talk to your provider, because every woman, I change up what I treat them with. You know, I have what I like to start with perimenopause and menopause, but based on your symptoms. And that's why I write down when you felt your best, like during your menstrual cycle. Because if it's in the beginning, you like estrogen. If you liked it at the end, or you like being pregnant, then usually you lack or you like progesterone. So knowing those things can really help in the perimenopause and menopausal phase. Menopause is usually 12 months without cycle, and then postmenopause. And usually if you're going to get hormonal treatment, we thought we could just treat people for 5 years. We found out that didn't work. The average is 11 years. And then you see if you can go off. But women who went off their hormones before that did not seem to do well. The biggest thing about hormone replacement is you just have to be a candidate. The biggest thing is obviously if you have a breast tumor, but having a controlled blood pressure, cholesterol, the exercise, controlling those factors will make it much easier, not smoking, to do hormones. The absolute contraindication is the breast tumor visits. But there are other non-hormonal treatments that can help, again, with hot flashes, vaginal dryness, that they're getting better. But ultimately, and I know Linda and I talked about starting to see an increase in your compounding and the FDA hormones. They're not FDA approved, but all the colleges say that we can use them if it's not available, say testosterone. Your ovaries produce most of your anabolic steroids, your testosterone. And if your hormone replacement isn't getting you where you need to be, that is a legitimate thing that you can ask your provider to see if adding some form of testosterone supplementation will help. It actually makes your estrogen, if you're taking that, more bioic. So it will make it so you don't need much estrogen. Those are just kind of, and I know the handout has, recommendations for hormone therapy and, non-hormone therapy for symptoms. But the biggest thing when you talk to your provider is write down what's bothering you the most, what you want most treated. And I know that then we can try to curtail the best treatment to spend you.
And would you guys mind just speaking up just a little bit so they can hear the microphones up here and we don't have a horrible one? Awesome. And Linda, did you have something to add?
just about the testosterone therapy, before Dr. Dwight came, I was really kind of hesitant to consider prescribing that because it's not FDA approved. But after talking to her, I've become a little bit more comfortable. I just want to say that for women who are seeking it for libido issues, it is not a silver bullet. We'll really put a lot into that medication. And as far as libido goes, it's a pretty complex concern. If you have low libido, it's generally not just related to testosterone, but a lot of different factors in your life.
Do we have any questions to start?
So you talk about peri and menopause. When do you know that you transition? I love that term into post-menopausal.
After the 12 months with no cycle.
Okay.
Which does, for some of my patients who've been on hormones from perimenopause through menopause, we've stopped their cycle. So to really get that postmenopausal definition, you won't necessarily get that unless we took their hormones away.
Plus, women with hysterectomies, you don't know.
Right.
Okay. And I think it's fair to say that doesn't mean symptoms stop,
Oh,
impact stop, right?
No.
So it might be helpful just to unpack that a little bit. Is you hear, oh, I'm post, I'm done, right?
Right.
But there's still going to be
No.
within the water.
I never
was in with doing some treatment, but definitely not.
usually the take home for one of the biggest risks is I always tell women, hormones won't give you breast cancer, but they can feed it if you have an estrogen sensitive tumor. And the literature, it can increase your morbidity taking estrogen, meaning you may need chemo when you wouldn't need chemo, but it does not increase your mortality. So I do tell people, if you're holding off taking it because you're worried about it feeding a tumor, it's not going to increase your mortality. Studies, the data shows us that. But the other is, like we talked about, cardiovascular risk factors. We don't want to give you a heart attack and stroke. And one of those is starting actually the estrogen within the first 5 years actually has a much better outcome. So I tell people, if you're suffering in silence and then finally break down, yes, again, we can give it to those people, but we might be more stringent on making sure you're not a smoker and your blood pressure is pristine and your hemoglobin A1C, which looks at your diabetic, your sugars, is great. I mean, that's how I look at these different risk factors, but
Up to date on all your
yeah. And but yeah, you just because you're a year or 5 years out of menopause does not mean that you're magically gonna feel really good.
And we have a question in the chat. Angela, go ahead.
Okay, so I have a couple questions, but can you explain hormone therapy and who may benefit and who should avoid it is number one, because some people can do the therapies, but some can't. And then what hormonal treatments or lifestyle changes can make and manage the symptoms?
Well, hormonal therapy, an absolute contraindication is breast tumor with estrogen positive receptors. There is some data that says that for vaginal dryness in those individuals who are on, especially tamoxifen, or if they're so many years out and their oncologist is okay, you can use vaginal estrogen. Really, a family history of breast cancer is not mentioned anymore because usually that is a genetic linkage. And if that is a worry because you have a high family history, then genetic testing is what you should do. But it would not preclude you from taking hormones. For individuals who do have breast cancer and they have vasomotor symptoms, you can give one of the newer medications that actually helps with the vasomotor symptoms, or something like clonidine. You can give some antidepressant medications that help with vasomotor symptoms. So there are a lot of non-hormonal options for the breast cancer patients. But the most you could give a breast cancer estrogen receptor positive patient would be vaginal estrogen. And again, that would be, I usually always ask their oncologist if they are okay. Sorry, what's the rest of?
I think there
Lifestyle
was an
intervention.
alternative.
Oh, yeah.
I mean, definitely, just in general, as we're in the perimenopausal phase and getting into the menopausal phase of things, there's a lot of data supporting that, like exercise for vasomotor, all that stuff is very helpful. Good nutrition, I generally recommend like Mediterranean diet because has a lot of grains and vegetables, low on animal proteins can be very helpful. And resistance training for your overall body mass and bone health. But also it can help you sleep better. I mean, if you have that exercise routine. And good sleep, like a lot of problems may be related to the vasomotor symptoms you're having at nighttime because you're waking up all the time because you have hot flashes. And so you have interrupted sleep. And then that itself leads into all kinds of other comorbidities. So if you can address the vasomotor and then see how things go, that's helpful. I just want to say another probable contraindication is a history of blood clots like DVTs, pulmonary embolism, as far as like the estrogen. Topical or oral, but vaginal estrogen may be also.
And usually my go-to start, the estrogen patch has less cardiovascular risk, so I like to start with that.
And less clotting risk. The bypass.
Great, yes. And I like a bioidentical progesterone that you take at night. And actually, when you have chest palpitations at night, it actually helps with that. If you don't have a uterus, you only need the progesterone. Some people need it. It makes them feel better. They sleep better. You only need the progesterone to protect against uterine cancer. So some of my patients who do not like progesterone, it does not work well. It affects their mood. You can do an IUD because the Mirena IUDs will produce enough progesterone to protect that uterus. So it kind of takes that progesterone out of the equation. They have other smaller IUDs that have less progesterone. Technically, they can work, and I have had patients who I put them in. The data doesn't support that. We don't have enough. But they also know that it's not the standard of care, and if they have bleeding, that they would have to have it painful. But it essentially, for me, the take-home message is I like to start with a patch and a progesterone. But if it doesn't work for you, you need to go to your provider and tell them what doesn't work and what works and how to make it better. It's a process. And I tell people if you're not happy, you don't like how you feel, or you feel better but not great, we want to get you back to great. We want you feeling your best self. And just coming in one time and getting the script and being like, I kind of feel better. There's a lot we can do and massage this process.
The one thing I would add that I like about the estrogen patch with the IUD as well is that you can do the estrogen that is at lower levels than you would find in birth control. The IUD will still prevent against pregnancy. So especially for women that are in that perimenopausal stage where they still have a chance of becoming pregnant, I think it's nice because you don't have to worry about that anymore.
And I believe Dr. Hankey has a question in the chat.
Hi. So two things. Someone had commented, I thought Linda talked some great stuff about things that we can do, but that Menopause Brain has great chapters on like supplementation with selenium and different things like ashwagandha or different things that can help. And so there's a lot of really great topics on that. My question is, this is where I struggle, and you guys kind of touched on this a little bit, but I get patients all the time that come from their naturopath and they want all their hormones done, and they want bioidentical hormones, and they want testosterone pellets, and I mean, that's so far away from what I have any knowledge on. What do you guys just talk to these people and offer like what we would offer based on the ACOG guidelines and stuff? Do you just say, listen, you just have to go through your, your naturopath? What are your recommendations there?
I generally don't do hormone testing for the most part, especially in the perimenopausal person, because, I do sometimes because people just want to know, but there's no value in it, in my opinion. I don't know if you agree or not.
I mean, if I'm working them up for something else, I might get their hormones for abnormal uterine bleeding, but rarely somebody coming in just complaining of hormonal issues or menopausal issues. Usually if I have someone who wants to be worked up, I'll ask to get their thyroid or their total testosterone. And, because other endocrine systems can actually bleed into your reproductive system and can actually affect the pituitary that it stimulates the ovaries to do things they shouldn't. So I will work them up if they have other issues, but it's not just for menopausal, perimenopausal. Then you're not going to gain really anything from
I
that.
do sometimes do an FSH for someone who doesn't have a uterus and is having symptoms that may be menopause, but may not be menopause, like someone who had a hysterectomy and is 50 and noticing some hot flashes. Well, I don't know if they're menopausal. They don't have a uterus, so they're not bleeding anymore. Likely they are. So I may order an FSH to check that. Because if it's not that, I would certainly want to investigate further because you can have hot flashes for a lot of reasons that are not related to perimenopause and menopause.
Well, I'm sorry, I guess to clarify a little bit, because I don't know what to do and what to do with those hormones. So I don't ever do that because I don't know how to adjust something based on those hormones. But the majority of my patients come in and they want bioidentical hormones and they want compounded hormones. And this is just not something I have. Like, do you guys just say, I'm sorry, you're going to have to see a naturopath? Or like, is there someone, I don't know what to do with that information.
I mean, yeah. I mean, I do compounded hormones and I do have some patients who, they just really want their estrogen, progesterone, testosterone. So I'll have them all compounded, all three of them. The problem with that is I've had patients do great on them for 6 months or a year and their biochemistry changes, their need for the hormone changes. I don't know how much is being absorbed and all of a sudden they don't do great. So I do caution my patients that, I usually will do bioidentical compounded testosterone because I can control it better. But the estrogen, progesterone compounded, I don't know the absorption really well. And there's a risk to that because I don't know if you're getting too much estrogen, very little progesterone, setting yourself up for risk of uterine cancer. So I try to caution them against using just only the compounded, quote unquote. And I know those are a lot of buzzwords and the pellets, I think they're injected for like 6 months.
Yeah, I just had a negative experience with someone that had pellets and postmenopausal bleeding. So I have no idea what you're getting, like how much of this is being absorbed. I don't know how to help you.
So I do cause, we feel the same way. If someone wants pellets or something like that where it's long lasting and I don't know how much is being absorbed or how bioavailable it is, I strongly caution the patient that based on the data, I do not do that. They can certainly find somebody to do it, but I don't think it's the safest route to go. And like a progesterone permetrium is an FDA approved form of progesterone. It's bioidentical, but I know how
Most of the estrogen we prescribe
yes, it's bioidentical. So it's other than the testosterone, which is not FDA approved for women. And I just like the compounded again because I can control the dose. Estrogen, progesterone, if you're taking a compounded, you're putting yourself at risk, especially if you still have your uterus.
Can you just explain, I had a couple questions, but just in this conversation, can you explain the difference? Was compounded a combination in one delivery of those hormones as opposed to, I mean, I'll say, like, I'm on the estradiol patch, which is a bioidentical, right? And then I take a progesterone pill at night. So that's what Dr. Gassman started. So that's different than a compounded hormone.
Yes.
That's what you're talking about. I understand that.
It's usually specialized pharmacies that will, like, you
Right.
still have to write out the prescription
Yeah.
and they'll put in that amount.
Yeah,
And
just
then-
like any other compound.
Yeah, and it's like a salve that you
suitable.
put on.
Okay. And can I ask, while we're on the topic of HRT, can you talk a little bit about, I think you answered this question, expectations on what, I know it depends on your profile and everything of just what to expect. Because there's a couple things like, I'm a data girl and I'm a number girl. So, you know, whether you increase your dosage, is that purely based on the patient coming in and symptomatic, saying, I'm still not feeling good, so we're going to go up to the next level. I remember having that conversation with Dr. Gassman, starting at the lowest and then working up. Is there ever a point where you would test for that hormone in your blood level to know whether you're still in a range or taking too much, or is it still just go back to like, how are you feeling? How you're feeling. Okay, I have a hard time accepting that because I just. So I'm gonna just be honest, like I think a lot of
I
people
get
are
like,
like,
you, a
you
lot
know
of
what I
people
mean? 'Cause
want
it's like blood sugar is blood sugar, this is
Yeah.
that. But you know, she
Yeah.
explained to me that, like you said, your biochemistry is always changing. So at the time you take that, it may not necessarily mean much by the time you go X amount of months down the road.
Well, and remembering too that like when you are having your menstrual cycles, your hormones are fluctuating already. And so I think that yes, there are ranges, but even for an FSH, I know I've read that sometimes you should check it twice
Yeah,
because
I
even
always
that
check it
level
twice. Yeah.
can vary. And so it's hard when there's not that cut and dry yes or no.
Right.
It's meant to feel uneasy about that.
So in terms of expectations
Yeah.
on, so like I'm postmenopausal, probably a good 5 years to it. I started HRT probably maybe 2 years ago. So I'm still kind of new on that. Is there, like joint pain is one of my biggest issues. But I don't think that hormone, that is a pure solution for that. There's also weight gain, heaviness on the joints, need to exercise more, like all those other things that you described. And I am following Dr. Mary Claire Haber and like working on that. But the joint pain is just like insane.
But maybe it's not related to your hormones. Like that's like, what is it that you're not feeling better? Right? Because maybe it's not related to menopause at all and that
Right.
needs to be investigated.
Something else. yeah.
Right, exactly.
Yeah.
I think with the attention that perimenopause and menopause is getting, which is wonderful because it allows the conversation to flow more freely. But I think that we're getting into a mindset that all of our symptoms are related to perimenopause and menopause, which a lot of times they're not, and we can't forget that part of the equation, right? Certainly trying HRT, see if you feel better, adjust the dosing, but if your primary concern is joint pain, then that joint pain needs to be investigated outside of the hormone realm.
Right. It definitely helped with hot flashes and
Yeah.
other things too. So there were multiple.
Right.
So,
Right,
but just with the expectation of
Yeah.
what that tactic, what that intervention,
Yeah.
you're doing, what to expect.
and I think just improving your sleep a lot of times can
Mm-hmm.
really make such a difference in how you're feeling overall. So someone said up there, will I ever sleep through the night again? I don't know, Kim. You might, I don't know if you're on hormone therapy or not. If you're not, you should talk to your provider who might be.
Is it an like wise tale that you'll have menopause similar to how your mother had menopause? Is that just a thing that people say, or is that a real?
I always ask that question.
No, it's
Okay.
actually true genetically. It's how you age. And we found that It's just like if your grandma lived to 90 and your mom lived to, 95, chances are you will as well. So no, it's a real,
Can you speak to the postmenopausal person that hasn't started HRT? How long of a window do they have before they could start it?
that depends on the person. Like I said, we'd like it within that first 5 years. That's my hope. That's what I love.
You have the most benefit.
Yes, and lower risk cardiovascular. Now, if someone came in at 7 years and again, low cardiovascular risk factors, they get their yearly mammograms and they're finally sick of it and they want to go on it. Then yes, I would do that. If someone else came in at 7 years and had many smokers, uncontrolled high blood pressure, high cholesterol, high blood sugars, then no, we'd suggest an alternative to that. So it's whether you can be a good candidate.
My question would be, what are the symptoms that you're concerned about, right? Like what,
Well,
you want to have a conversation about hormone replacement therapy. Why? What are you experiencing?
what about the protective benefits? Or like they got through the hormone, the symptoms, but you want the protection that you learned, that we've learned about that.
Get the most protection the earlier you start it. And I think, I don't know if you agree,
Like
but
cardiovascular, bone
Right,
density, all
right.
these
The
things
further
that
out you
we're
get,
learning about.
you're more risk associated with the HRT, maybe not as much protection. So if that's the primary goal, it's like a real conversation about just the
That's
aging
helpful.
risk and then adding the HRT into that. Like,
I think that's why too, it's so gray, right? It's not black or white. And you can have two people and they can have completely different plans. And just like, as primary care, also remembering the importance of all of those screenings. Yes, mammograms and everything. I think about cholesterol too, because menopause and the fluctuations in hormones can actually affect your cholesterol. Estrogen actually keeps your bad cholesterol down when we are younger before menopause. Progesterone helps boost our good cholesterol. And then when we go through menopause, you can start to see the opposite effect where women's bad cholesterol will start to climb and their good cholesterol will go down. And so kind of remembering that, another thing that I've started doing in my practice, because it's hard. I feel like it's hard when we're finally talking about menopause, when I see women who are outside of that 5 to 10 year window and have to kind of say, well, I don't know, because it's a little more risky for you. And so there are some other kind of tests that you can do to really get a sense of someone's cardiovascular health. And so something that I will often order is something called the coronary calcium score, to actually look at someone's coronary arteries to see how much calcification is there. We're thinking about cardiovascular risk. Again, it's
Wait,
not,
you get that covered?
no, so that's, I often have that conversation too. Some of these things are not covered yet. That test in particular is under $200. And so a lot of my patients, they feel like it's worth it to know that piece of information before they're trying to make this decision. But there's a lot of different pieces that go into it.
I do say vaginal estrogen for anybody that you've had like a.
Actually, if you've had a endometrial cancer and you've had a hysterectomy and you haven't needed chemo or radiation, you can have vaginal estrogen.
You know what this from?
Sorry. The most common type of endometrial carcinoma. Usually if people come in, we find it early, and most of the ones that I've diagnosed have very little penetration into the uterine tissue. So it's just a hysterectomy, and that's curative. And studies show that they can have vaginal estrogen. We continue.
We do have another question in the chat. Can you speak to how peri and menopause is different for women with PCOS, especially those who haven't had normal cycles in decades, if ever, and how HRT recommendations may differ for them?
PCOS as a whole. Sure. It would totally depend on the person. Usually PCOS individuals will, especially if it's not true PCOS, but insulin resistant. Because insulin actually stimulates the pituitary gland, which then stimulates the ovary to produce the bad type of testosterone, the sexy type, but the type that makes us lose our hair. And that is converted in adipose tissue to estrogen. So insulin resistant, which is a lot of what I see, they have this unopposed estrogen and this bad type of testosterone. And if they are left untreated with progesterone, that could lead to uterine cancer. So somebody who's had a history of irregular bleeding and PCOS, that's when I would do hormones. I would do a huge workup to know what I'm dealing with. And then I would make sure that they had progesterone because their risk of hyperplasia, meaning abnormal growth of the endometrial tissue.
And we did send out a form prior that people could submit anonymous questions. So I do have one from that as well. That kind of goes along with that. In terms of irregular cycles or not knowing their cycle, if they're on birth control and don't have a period or haven't in a long time, but presume it's because of the birth control, how do they know? And when do they start talking to their primary care physician about that?
They're on birth control already,
That's how they pose the question.
so they're already taking hormone therapy.
Presumably.
I mean, the easiest is to stop it and see how they feel. Again, like Linda said, what are their symptoms? If they're taking birth control and something has changed, meaning you're feeling different. Maybe it's not enough hormone to make you feel better. Then I would work up the symptoms. But if it's just you haven't had a cycle because you're cycling with birth control and you don't know if you're menopausal, the easiest way is to stop taking it for a month or two. Write down how you feel.
And it kind of goes back to Trisha's point about that. How true is it that it can be based on like our genetics? And I think, talking to female relatives to get a sense of how old were they when they went through menopause can give you an idea of what's kind of expected. Like the average age is 51. So if you get to that point, I think it's reasonable to try, knowing that you could make that transition from the contraceptive levels of hormones to HRT, where the estrogen and progesterone levels, at least estrogen is lower.
I would be concerned, like if that person is taking birth control and they're having symptoms that they feel is related to perimenopause, I would want to be working them up outside of the hormone realm of things because they're already taking hormones. Like, why would they be having, if they're complaining of hot flashes or whatever? I want to investigate that a little bit more before I say, oh, let's just change it.
Yeah.
Maybe your menopause, let's stop it and see if there's.
Do you have any questions in the room? We have another one in the chat, but I want to give you guys a chance.
No one asks questions about libido?
There is another anonymous question. If you want to, we'll go to that one. There was an anonymous question that asked, what is the recommended treatment for low libido during perimenopause?
In the United States of America?
Sure.
Or beyond, I guess.
We don't care if our women have a low libido, we just have to deal with. That's pretty much in the US, there's no real treatment. It was research for an antidepressant, and we found out that it actually helped libido. You had to take a test online and send it in if you were going to be a provider who prescribed it, because the doctor who was on the panel for the FDA, FDA said they were hesitant to give it to women because it made you tired and we might get tired dropping our kids off at school. That is a quote I will remember for the rest of my life. It angered me a lot. It still does. It's been a long time. And of course, we all know, I mean, Bag or Cialis and, you know, the commercials for I have low T because, you know, you could be a 20-year-old and walk into your doctor's office and say, which, you know, but, and it's all FDA approved. For women, as Linda said before, you know, low libido, there's a lot. It could be vaginal dryness, sex hurts, you're not wanting sex. It could be a relationship. It could be, you know, you're not sleeping. So usually low libido is, and sometimes it can be long discussions. However, I have had patients come in and they're like, I've always liked my significant other and I really enjoyed my sexual health with that person. And in the last year, they're still a great person, but I don't want sex and fix me. So, so for some people, I will start with just hormones, but if someone comes in and it's not just low libido, because low libido is like going to the gym. If you don't go to the gym, you just don't want to go to the gym. But if you work out all the time, you're gonna miss it. It's the same with a good libido and a good sex life. You can't just, you have to work at it. The question I usually ask again after how's your relationship, how is your self-care, is how hard is it or easy for you to achieve an orgasm once you do? And if they're like, if the patient says, fine, once I'm in it, I'm glad. But if a patient who has a great relationship still likes their significant other, used to have no problem, and they're like having an orgasm is like climbing Everest, then that's when some testosterone will help. Again, it's also having a regular, healthy, you kind of have to schedule sex, like scheduling, going to, yes, you might want to do dishes rather because the dishes will get done. Sex, nothing will get done. But your libido and your sex life will get better if you schedule.
It sounds so boring, but there is a lot of research that
Yeah.
supports that.
Yeah, we're not making this up.
Yeah. There are a couple of oral agents that have been developed for women for low libido. I prescribed one of them a couple of times and they were discontinued by the patients. They helped a little bit, but the side effects were so bad that they just stopped taking them. And again, testosterone is all over social media. So that's a question I thought we were going to get the whole time.
So the one in the chat was, how early is too early to start HRT? I feel like my physicians are hesitant to give me HRT unless I'm having hot flashes. It feels like that's the qualifying factor, but I have all the other symptoms: hip pain, brain fog, night sweats, acne, etc.
Yeah. Again, it depends on the individual. It's, as Linda has touched on before, it certain symptoms like that, I probably wouldn't just throw HRT on them. I might do an actual workup and look to see if there's something else going on that would be better corrective going in another path. But if all of those are normal, and I've worked them up, and yes, I can see discussing and seeing how they do.
I guess my question for that person would be, like, are they perimenopausal? And what are their periods like? I mean, the earlier, in my opinion, the earlier, from what the data is saying, the earlier the better as far as like the possible benefits of HRT. But we also have to remember that person